So I think we'll go on to Dr. Jayanta Das to tell us about the vexed problem of anophthalmic, the congenital anophthalmic sockets, which is a difficult problem to treat.
Thank you, sir, to include me in your IC. So, as Dr. Tarzani, Dr. Salu, Dr. Rituja, everyone mentioned all points. So that is another hurdle for us is the congenital anatomy. That means nothing from the birth. Sometimes it may be a very, very contracted one, or sometimes maybe with the cyst. First of all, as our first primary aim should be the volume of the socket. Until and unless we will, that primary aim for a congenital anophthalmic socket is that not for a prosthesis or something. We want to make the two cellens. Second is the volume of the orbit. Congenital anophthalmia lead to orbital bony hypoplasia. If we want to prevent bony hypoplasia, we can go for a expander. True congenital anomalies, of course, is rare. So this is a gift for us. Sometimes it is associated with the and microphthalmic cyst, microphthalmic eye with the cyst. If there is a cyst, we can assess the cyst by radiological or clinical. Then we can allow that cyst to retain. So it will help for further bony growth. Otherwise, if we excise, there is a tendency for the young surgeon to excise the cyst. This is not a ideal choice. So if because that in practically for a ZA, it will be difficult. In an institute, it will be easier to tackle some surgery under ZA, but in a practice reality, it will be little difficult for to a kid under ZA, and it is expensive also. It may be a decrease, as my previous speaker all mentioned, there may be the decrease in horizontal or vertical, whatever are all taken care. Without treatment, the patient may develop 20% decrease in the size of the orbital volume at the end adult stage, or volume and orbital entrance, that is in the rim. So there is a big challenge with a congenital one. So there may be a problem with the rim, there may be a problem with the volume also. Managing complications associated with anophthalmic socket, but it may be because there may be association of other the socket contracted socket related issues also may be there. For any that is already mentioned by our previous speaker, so those are the points that implant sufficient volume. I am stressing on that. That is for congenital volume is one of the point, and that there may be associated. Salu already mentioned lead abnormalities. There may be other abnormalities with the contracted socket. There may be lead coloboma, etc. We can take care one by one for a proper cosmesis. The essential this component to establish to maintain to be chronic irritation. So chronic irritation and others should be deferred. So for that evaluation, it is very, very important to the size of the microphthalmic cyst, location of the cyst, and the it is enlarging or not. Sometimes it may be static, or sometimes it may enlarge along with the ages also. So initial treatment is progressive socket expansion, but another big problem is that if it is a true or cyst is very small, then we can go for a socket expander, but it is little expensive. So in such cases, then in our routine practice, we can go for a conformer exchange. My one technique is that conformer exchange. We can go for a conformer exchange if required, as long with that phonics forming suture, we can try it. And if we do a tarsography along with that conformer, sometimes as it is little easier in a congenital because it's more elastic. Because of the elasticity, it may grows also. So that's another added advantage in that a contracted in a congenital. Lots of procedures already. My previous speaker that mentioned all those things, but in young kid, that's another big important is that it should be done under GA. Even sometimes examination also we may need a EUA. So that's a big issues for each and every time. So for and proper radiological evaluation also may need a sedation at least. So those are the some other issues with that. So better we can jump for an assessment how much we will go for a, suppose we want to go a dermophed graft at what age, and how much we will go for a implant, because that it grows up to 6 years only or 7 years, and parents do not want to wait for, because that preschool another issues. So generally 4 years one of the crucial part before going to school. Anyhow we should fit the prosthesis, that's for his kids psychology. So we can look for the psychological impact on the child, the psychological impact on the parents and as well the family members. So some other kid may point out his part, and that child may not go for school. So all factors we can look it, and then as I already mentioned, so we can go for a socket expansion by a different conformer and with a phonics forming. This is one of the easy, and then we can go for a ultimate. Once it's achieves some amount, then we can go for a permanent one, either a secondary ball implant or dermophrade graft, the solution. In a worst cases, the dermophrade graft, but basically nowadays with a advancement with the others, we can go for a secondary implant. And before that we can assess all, and that the surgery should be very very meticulous, as Dr. Tarzani already showing that it should be a very very meticulous surgery. Is generally evisceration, enucleation in our previous textbook it was mentioned as a destructive surgery, but for an oculoplastic surgeon is a rather is a constructive surgery. We should take care all antibiotic, everything should be in a proper. Sometimes before for a final volume replacement we can go for a mucous membrane graft for surface if there is a deficiency on the, this is the only indication. If there is a surface deficit we can take care for the surface, then only we can take care the lid abnormalities. There is a complex situation, one surface, volume, and the lead anomalies. All we can take care one by one. So we can think for one, two, one, and then think. Of course, for retrieval of the mucous membrane, in a pediatric, sometimes that leap may not be sufficient. So we may need a repeat one. Then, of course, that we can go for a sick one. It is more voluminous and it is cosmetically also more acceptable, little difficult, but as in the kid we are doing always under GA, so it is an added advantage. We can use it from a that one, but leave is one of for best for adult, but from the sick in case of adult, because under the GA, so that our other problems are not like in others, but we can use in a like a from lip also. Then we can go for one by one. Once we can volume, and simultaneously we can treat but volume by a secondary ball implant or dermopregat, or that also we can implant in. If we taken care all tenons, conjunctiva, etc., then we can graft for it in one set by a surface also. I will not go for a in details all already. That's one. It is a dermophed graft. In congenital, sometimes there may be, if the socket is not so healthy, we can assess the vascularity also. For vascular, if it is a no, it is a relatively good vascular, we can assess the vascularity of the orbit by the Doppler. That is one option, is that we can assess somehow. There may be some other anomalies with that vascular pattern also in the orbit. So accordingly, we can assess, either we can go for, you can go for a secondary implant with that directly, or you can go for a dermophed graft. For a dermocare, some amount of there should not be any compromise on the vascularity. Otherwise, that graft may there may be some necrosis, there may be infection, there may be a more, more fat uh, atrophy in later. So those are the points, as my previous speaker already everyone mentioned all those points. But what if we not treat? What are the others? If we delay the treatment, or if you not taken care in proper, what will happen? One is the contraction of the fornixes furthermore. Second is the anophthalmic ectropion, also another late anomalies, ptosis, less margin ectropion, and one is the cosmetic optic. As I already mentioned that it is a gift for us if with the congenital and ophthalmic socket associated with a microphthalmos, and luckily most of the time that there may be a large or moderate or even the small cyst is always there, so we can utilize that cyst as a volume expander. So it's generally 7 to 14 in mm, millimeter in most of the time, cysted line internally by glycotic retina and externally by fibrous envelope. Rarely globe can be normally in size. Very rarely, sometimes you can find out in histological load. Those are the points. It was not taken care in early stage. So later on, you see there is a eyeball, microphthalmic eyeball with calcification, and there is a cyst. So she's a little lucky enough. So simultaneously we can go for a, in adult cases we can go for a cyst excision, and the same sclera we can mobilize. Now with a technique of our technique, we can utilize whatever the sclera, four petal, or we can mobilize the sclera. Ultimately we want to cover the anterior part of the sclera, not necessarily is a, we have to cover whole the sclera. So that's the advantage. So advantage of that is a, the same sclera we can, if we utilize it, so there may be a chances of infection, chances of rejections, and of course we can prevent there is a transmission of some other disease like a hepatitis B or the HIV.
Jayant, can you summarize
Yes,
now?
sir.
We'll
Yes,
have
sir.
last talk left.
So clinical characteristics are just I want to summarize. Those are the some steps of those things, and ultimately we can achieve. So I want to conclude like with that. Though congenital anomalies give a cosmetic disfigurement, but appropriate and meticulous management of such condition is helpful for better cosmetic appearance. Missed out clinical diagnosis can be confirmed by CT scan. So if there is a cyst, etc., we can take care. Thank you.